This case will demonstrate the replacement of a missing lower molar. The dental history is that there was an extraction of a fractured mandibular left second molar, which was extracted 6 months prior. Further dental history on this patient is all within normal limits. The diagnosis on this patient is that in this particular second molar, sufficient bone width of more than 8 millimeters is available. More bone height than 10 millimeters is available. Presence of keratinized gingiva is sufficient, and that there is a stable occlusion with canine guidance. The treatment plan for this patient is a flapless surgical procedure, the placement of a wide platform 10 millimeter length Noble Direct implant, an immediate temporization, then the allowance of 2 months of osseointegration period, with the subsequent final crown fabrication. Clinically, we see here a sufficient amount of mesiodistal space. We see a sufficient amount of keratinized tissue and a sufficient amount of bone height, which was diagnosed from a radiographic finding. This implant system uses the normal sequence of drills. As you can see here, the first drill is a 2 millimeter twist drill. Then we use a parallel pin to guide the punch over the parallel pin to excise precisely the gingiva for a flapless procedure. The following drills are just utilized to increase the dimension, and they follow the tapered Nobel replace drilling sequence with a final insertion tool to insert the implant. The clinical appearance, as you can see here, most importantly, is really to preserve the gingival tissues as well as to stay within the bone. So it's very important to diagnose these patients, which we're going to use the flapless procedure, to have sufficient bone and sufficient soft tissue. The first drill will be using a 2 millimeter drill to perforate the soft tissue within the keratinized tissue in exactly the optimal position for the later implant placement. The depth we'll be looking for is 10 millimeters in this particular patient, and that's the perforation within the bone, as you can see here. 10 millimeters, utilizing the gingival cuff included in this 10 millimeter measurement. The surgical parallel pin, which is going to be guiding the punch, will now be inserted, and it will fit exactly in this 2 millimeter drill. It will also demonstrate that we're staying within the keratinized gingiva, so not jeopardizing the keratinization. The next drill is the guided punch drill, which will only excise the gingiva. So the goal is to make a very clean, round cut within the gingiva, which is being guided by this surgical pin. Now we can see the demonstration of this clear, round excision of keratinization, and in the middle you can see where the 2 millimeter drill perforated the gingiva and the bone. A surgical spoon can be utilized as a removal tool for this gingival tissue, and a clean entrance to the bone is now demonstrated. Some extra soft tissue can be removed with a small scalpel or with a curette. The next drilling procedure now just follows the drilling of preference, either following the industry's guidance or the preference of the clinician. Here a twist drill is being utilized, or you can use a tapered drill. Important at this moment is to have measured the gingival height, which in this case was 2 millimeters, to include it in the drill. After the first drilling sequence, a procedure is followed where we go to the tapered drill, which has to include the height of the gingival cuff. So you can see here that the 2 millimeter height of the gingival cuff is being included in the depth of this drill. So it means that actually our reference point becomes our gingival height, and so the total drill is going to be 10 millimeters bone plus 2 millimeters of gingiva. So if the reference point is the gingiva, it's going to be 12 millimeter in total. And that's what you can see here, that we're like positioning this here in such a way and demonstrating now the ideal mesiodistal position, buccolingual position, as well as the ideal vertical height. Now here demonstrated in this particular case. Now important is always to evaluate the density of bone. So in this particular case, we're evaluating this here and have concluded that the bone density is probably quality 1 or 2 in this male patient with a posterior mandibular indication. So a screw tap is being utilized to the full depth of 10 millimeters to prepare this site to receive the implant. And this is a decision which is made by the clinician. An implant then is being picked up, the Noble Direct wide platform, 5 by 10 millimeters. An insertion tool is being utilized, and the implant is being picked up out of its titanium vial to stay in a clean, sterile condition, and now inserted through the gingiva straight into the bone. The surgical handpiece is being utilized first at 20 Newton of torque, and then slowly incrementally increased to a maximum torque of 40 Newton. Our minimum torque, as you can see here, is demonstrated by 30 Newtons. That's what we need for an immediate temporization. Important here to demonstrate that the implant is seated fully, that the threads of the implant are in bone, and that this implant as well is going to be in a position that there is no interocclusal space interference. In a final positioning, a manual wrench can be utilized where the maximum torque of 40 Newton is ensured. And you'll see that implants like this are being placed with a manual torque wrench to this maximum level. Then a check is done so that there is no interocclusal interference with the head of this implant, and that we are in proper position for restoration. In the pre-planning of this particular patient, a diagnostic wax-up was done, and an acrylic shell was fabricated on the study model. An occlusal vent hole was prepared to allow for the retrofitting of the acrylic to have access through this occlusal hole. This then is being used with additional acrylic, where we're seating it directly in the mouth on the patient's implant, as you can see here. Important is, when we're using acrylic, that there is no undercuts, and the little screw access hole on the implant has been closed or has been occupied with some wax or even some little cement, so there's no acrylic being picked up there. Now we can see here the retrofit of this particular acrylic restoration. You can see a narrow occlusal table. And important, as this is an immediate temporization, an immediate function, that we have no occlusion on this acrylic restoration, and that there is no interference when the patient goes into lateral. So here an occlusal check is being done with occlusion paper, and we make sure that there is absolutely no interference on these patients. And as you can see here, we check that very precisely, and we make sure that all the occlusion is on the adjacent teeth. One more time in summary. On the left picture you can see the acrylic restoration retrofitted with acrylic. Then we're going to do a reline of the temporary. As you can see, very carefully done, so no acrylic or cement migrates subgingivally. We're going to maintain the acrylic margin supra or pergingival, so there's no wound injury, and we're going to apply a narrow occlusal table so the occlusion can be limited as much as possible. Based on good bone quality, based on good implant stability, we'll wait in this patient 2 months for full integration period before we start the final reconstruction. On the left side, you can see how the soft tissue has healed, even got some creeping attachment, and full healthy keratinous gingiva. On the right side, you can see how the temporary was maintained in position for the full 2 months. After that period of healing, the patient is called back now for the preparation of the titanium head of the implant. The temporary is removed, the site is cleaned, and then a diamond burr with copious irrigation is being used to prep a margin to host the new crown, the final crown. We're going to stay with this prep margin just like slightly subgingival or even pergingival. As you can see here, a slight subgingival preparation has been made with a sufficient chamfer so the crown can be placed. Then a subgingival cord is being applied to allow for just minor amount of gingival displacement so we can now pick up this margin in the appropriate impression technique. Careful positioning this cord is important, as the cord can of course be displaced deeply into the site. Then a light body impression material is being utilized to pick up the margin on the titanium in the same fashion as we would do it in a crown and bridge impression technique, and a heavy body full tray is then being done. Here we can see the impression, the accurate demonstration of the margins of the titanium. And temporary is being placed back, adapted to the site while we're waiting now for the final fabrication. These photos demonstrate the preparation of the titanium of the Noble Direct, and of particular interest here is the vertical groove which was placed on the buccal to resist any kind of rotation of the crown on the titanium. On the right photo, you'll see the demonstration already of the final crown which was made by the dental technician. And here on the next photos, you'll see the occlusal position of this crown, which can have a slightly larger occlusal table. Still, I prefer to go with like a more narrow approach on this posterior implant position. And then it's cemented with a normal cement, can be a glasionomer cement or a zinc phosphate cement, onto the titanium. The next photos are demonstrating then here the long-term result on this particular implant when it was placed, and a 30-month follow-up demonstrating bone stability within normal limits and with a normal remodeling demonstrating. So demonstrates the long-term result functionally as well as aesthetically of this posterior molar.